Okay, so we're going to talk about NG insertion. So before you go in and do an NG insertion, you're going to need your NG tube, okay, and then your connector. They come together in a packet and they also come separately. You'll need your tummy syringe, a container, a towel, and some lubricant and some non-sterile gloves. So obviously you've introduced yourself to your patient and explained the whole procedure. You've made sure that there is an order for it. And you're going to find out why are you putting in that NG. Is it for decompression or is it for feeding med installation, fluid installation? You're then going to, once you know why you're doing it, determine the right size for your NG. So you're going to take a look at your patient and see how big are their nares. You don't want to be grabbing, a giant NG that's going to include their entire nair. Once you've looked at them and decided, you're going to obviously check which side of doesn't really matter normally to the doctor which side you put the nasogastric tube in, just as long as you put it in. So I normally get in there and I just ask them to go ahead and sniff from each side. Do they have polyps on one side? Do they have a septal deviation? Whatever. I normally just ask to make sure that they don't have any, do they have trauma at some point? Something I need to be concerned about. And so then the very first thing I'm going to do is I'm obviously going to put on my gloves. And then I'm going to measure my tube. So I'm going to measure. So before I measure, I guess I should show you how to put it together, huh? So it comes separated, and if you'll see that there's a big hole and a small hole here, and there's a big connector and a small connector. So you really can't put it together wrong. You could try. I'm sure people have. It would take some brute strength, but you could try. You're just going to put it together like this, okay? And so then it should be together like this. Now we'll go over this connector here in another video when we're talking about med installation. But so now I'm going to measure. So I'm going to measure, we all know, from the nose to the earlobe. And I'm going on this side. I'm reaching across the patient just so you can see on the video, but in real life I'd be doing it on the side that I'm standing on. So I'm going to go from the nose to the earlobe. From the earlobe, I'm going to go down and I'm going to feel for the xiphoid process. And then best practices is that you add 6 inches, which is roughly 15 centimeters, give or take, okay? So I'm at 52, so I'm going to go to 65, okay? So I know that I'm going to go to 65. What I would do is either with a Sharpie, put a line here, get a piece of tape and tape it, and so that I know that 65 is where I'm going to. So I know that I'm marked. I'm now going to go ahead and just place a towel over my patient. Make sure I have, if they're allowed to have sips of water, it'll make it go easier, but you have to know why you're putting in that NG. Maybe the patient can't swallow, which is why we're putting the NG in, and we don't really want to give them water to try to swallow that NG. So we're going to say that my patient cannot take sips of water, okay? Because that way you are going to make them go through the motions, but they don't necessarily can't necessarily swallow. Just when you take the tube out, sometimes it's nice if you coil in your hand a little and kind of warm it up a little so that it's a little bit more malleable, because they are pretty stiff. And if you've never had an NG tube, they're really uncomfortable. So you could just get it a little bit more malleable when you're going to go ahead and put it in. Okay, so got it nice and malleable. I know that I'm going to 65, and I will have marked it with my pen or my Sharpie. So see my line right there, okay? So now I'm going to go ahead and put it in. So the first thing I'm going to do, I'm going to have the patient sitting straight forward, head neutral, and I'm going to push this so that it's parallel to the nasal cavity. So I'm not going to be shoving it upward. If you'll look at the nasal cavity, it's typically you're going to go in more like this, okay? You're not going to be shoving it in like this. I know that's your instinct, but really when you go to put it in, if you take a look, you're more, the tube is going to follow as long as you're not violently shoving it in there. It's going to follow the nasal passage, but you don't want to be starting like this, okay? So I'm going to go ahead and I'm going to keep their head neutral, and I'm going to push it in just a little bit until I hit the end of the nasal pharynx. And you'll know when you hit the end of the nasal pharynx because they'll cough. They'll be, ah, okay? So he's done that. So now I'm going to get him to bend his head down. I'm going to get him to chin tuck, and now I'm going to get him to go ahead and just swallow. he's swallowing his own spit, that's okay. Just need him to swallow. So I'm going to go ahead and swallow for me. Swallow, keep swallowing, keep going, you're doing great. Keep swallowing, keep swallowing, keep swallowing. All right, if I meet resistance, what do you need to do? Should I keep shoving? No. I'm going to stop for a minute, pull back, let him catch his breath. And then I might need to reposition. So with my guy here, I'll remove that pillow just a little bit so I can have a little bit more of a chin tuck. Okay. Are we ready to start again? All right, here we go. Keep swallowing for me. Keep swallowing. There you go. Y'all, you're doing great. You're doing great. Keep going. Keep going. We're almost there. Almost there. Keep going. Keep going. Keep swallowing for me. And we're going to say that I'm at my mark. Okay. If they start to gag, then you've probably hit the wrong tube. You need to stop and pull back. Okay. And there'll be a sheet at your skills station that walks you through everything, as long as Elsevier does as well, of what to do to troubleshoot if you have difficulty putting in an NG. So I've got it in there. Now the next thing I need to know is, am I in the right spot, right? So I'm going to tape it down. We have holders that can hold it in place. You can have tape that you chevron, so you take the tape and dog ear it kind of and hold it into place. We're going to say I've taped it, and now I'm going to check my placement. So I'm depending on what the tube is there for. Okay, so if we're there for decompression only, you'll see a lot of nurses will just shove air through. Air is only telling you that air is moved through a tube. It doesn't necessarily tell you that you're in the stomach. So it's for decompression. I'm going to go ahead and attach my syringe. And I'm going to aspirate, make sure I get gastric content. Okay. If it is for installation of medication or fluids, you have to get an X-ray. You cannot use the tube until you know that it's in the right spot if you're instilling. If you're withdrawing, as long as you get gastric aspirate, you can connect it to the suction. Now, let's say it's the next day. We already know that my tube is in place. It's taped, it's been verified by X-ray, so I know that it's where it's supposed to be, or at least it was yesterday when we inserted it. So now what do we do to make sure that we know this tube is in the right place and patent? So I've come into shift. This is pinned to my patient's gown. There are a couple of things you're going to do when you're assessing for a patient with an NG tube. So first thing I'm going to do is I'm going to look at the nares and make sure I don't have any skin breakdown. This is sitting right up against the nares, so if it's been in there for a bit and it's rubbing and moving, you can have skin breakdown. So you want to check to make sure that I don't have any skin breakdown up in there. As I'm looking there, I'm looking to see where is that taped mark that the previous nurse had when they inserted the NG. That's why we tape it, and that's why we have pen mark and we document it in the chart. Is I need to know. So if I'm looking at this, I'm going, oh, well, my pen mark's way down here. So is my NG in place? It's not. So what do I need to do? Well, I need to insert it some more. And then if I'm instilling meds, I have to get an X-ray, because I need to know that when I shoved it back in, it went back in place. Okay. So you want to make sure when you put the NG, you've actually taped it well, because that's a lot of extra for the patient. So we're going to say that it's taped and it's at the right spot. So now I'm going to check for gastric aspirate, so I know that I'm in the right spot. So I'm going to pull back. As long as I get some gastric juices, then I know that I'm probably in the stomach. Okay. I'm going to, if I'm already at my mark and whatnot, I'm going to make sure I give back my gastric juices, because it has all those electrolytes and stuff in it. I'm then going to check patency. So I'm going to pull back and I'm going to get checking patency with 20 cc's, 30 cc's, sorry, of fluid. So I'm going to have my 30 and I'm going to just push it in and make sure that my tube is nice and patent. Okay. And now I know my tube is patent. I'm going to look at my suction. I'm going to make sure I'm at whatever the doctor's ordered, normally low wall suction. Okay. I'm going to look to see how much output I have. I'm going to make sure that it's been marked during my shift change. Okay. Thank you. To start talking about medication administration for the NG. So when you have an NG already in place, you're going to have this connector. Now, this connector, if you take a look, it has a little blue mark right here. And that blue mark tells you which section of the controller is open. So it's turned this way. This one is to suction and feed. This one is hold or off. And then this one, it has a picture of a syringe. So this is going to be where you're instilling medication or irrigating, okay? Now, with this, I want to show you guys something really important. So when you take a look at your NG, your connector, if you see right there where my finger is, when I push the syringe in, you'll see that there's a seal right there. When I push the syringe in, that seal moves. That silicone seal has to move for you to be able to push the fluids in. So when you are instilling meds or doing anything with this connector, it is important to remember that your syringe might be this big and might be this full of fluids, but your opening is only that big. So it doesn't matter if I have 100 cc's in here. If I hook it onto here and push as hard as I want to, you're going to get some spray back because my opening is still only this big. So the important thing to know about this connector are a couple of things. One, this connector itself can occlude. So it could be that there were meds pushed through it before and they crystallized and it's gunked up. So you can go to the Omnicell and replace just this connector, okay? The point of the connector is to make it a closed system. You'll see some people will take that connector off and connect their syringe straight to the NG. We don't want you to do that because now it's an open system. So if the patient coughs, burps, you know, has a lot of intrathoracic pressure up there, what's going to happen is you're going to have backflow and you're going to end up wearing gastric juices. That's why we have this, okay? But with this, there are some, you do have to treat it with some little bit of respect. It is only that big. So however much you're going to push through, you need to be respectful of how big is your NG tube. The other thing is you do have to, the reason I pointed out the seal is you actually have to break that seal. So you'll see some nurses come and they'll put the syringe here and they'll start to push and they'll spray back at them. It might be that they didn't push and break that seal. With this connector, if you actually push down and twist, it will actually stay connected. So you don't have to do the whole manipulation and try to hold and push at the same time. But you do have to push down and break that silicone seal. So that being shown to you, now I'm going to talk to you about medications. So you come in, you've assessed it's in the right spot. It's marked in the right spot. It's still sitting there. You already have checked placement. You get gastric return. And now you're going to check patency. So check patency. I'm going to pull up 30 cc's. And this should be sterile water, not tap water, sterile water. And I'm going to turn my dial so that it's to the syringe. I'm going to push and twist. And now I'm going to slowly administer the fluids and making sure that it flushes with ease. Okay. If it does that, then I know my tube is patent. So now I'm ready to administer my meds. So what I'm going to do, your medications, hopefully you're in liquid form, but there's a lot of them that don't come in liquid form and we need to crush them. So you see I have my medication in here. You are going to take your sterile water. You're going to add 30 cc's of water. That is what best practice states now is 30 cc's of water. You're going to mix it up and make sure that it's nicely diluted, okay? So now you have two choices when you're going to administer the medication. You can suck it up in the syringe, which is perfectly fine. Just when you do that though, you need to make sure as you're sucking it up, you're going to start turning your medicine cup to the side so that you start getting everything that's sitting, all of the leftover dissolved medication needs to be gone from your medicine cup, okay? Then you're going to attach it and then you can push, right? So I've attached, I'm pushing my meds in. Well, now that I've pushed it, I now need to flush in between each medication, which means I'm going to have to pull up and flush with 15 between each pill. So if you do it this way, you're going to be doing a lot of disconnecting, connecting, disconnecting. If you say that there's pills in here and I've done 30 cc's, and let's say I have 4 pills I need to give. If you do it this way, so take your plunger out, I'm going to connect it, push and twist, right? I'm going to make sure my finger is on the lever so that I can stop it once I've poured my meds in, because I don't want to give all of my patient a ton of air every time I'm pouring a pill in. So I'm going to put it in the off position to start with. I've already checked my patency. I'm going to pour in my 30 cc's, raise it up so that it goes in by gravity. And as soon as it finishes, I'm going to switch it to the off position. Notice as soon as the meds got in here, I stopped it. I'm now going to pour my 15 cc's of flush. I'm going to flush. Now, if I had another pill, I could just pour the other medicine in, open it, let it go in, stop, pour my flush, and there's not a lot of connecting and disconnecting, okay? So I prefer the gravity method. And then when I'm done, let's say I've given all 4 medications, I'm going to flush with 30 at the very end to make sure that all of the medications are through. When you're doing medications, each med must be crushed separately and given separately. So you cannot, and I understand you will still see people crushing all 6 pills into one fine powder, mixing it with 30 cc's and being done. Although they might be compatible when you look them up, what they were finding with best practices, they might be compatible once they've hit the GI tract and have all of that acid to digest it, but that they were interacting within the tube and then causing obstruction. So each pill must be crushed and given separately. You're going to mix each pill with 30 cc's of water, and you're going to flush in between each pill with 15. All right, thank you.